Okay.
Good evening, everybody, and welcome to the New York Open Center's six-part series on the psychedelic renaissance, past, present, and future. This evening is our fourth evening in the series, and we are delighted to have Rick Doblin from MAPS and Michael and Annie Mithofer with us speaking about PTSD therapy with MDMA and so on. So for those of you who are new and who are just joining us this evening, because I know we have some new people with us this evening, let me tell you a little bit about the New York Open Center, as I know we have people from all over the country and I think all over the planet actually. So the Open Center has now since 1984 been the leading center of holistic learning and world culture in New York City. And we do a year-round spectrum of programs on all kinds of different dimensions of the holistic and ecological worldview. So you can find out more about the Open Center at opencenter.org. And as I've mentioned previously, a couple of the events that we've already done. Brian Mura Rescues on the possible use of ergot and related substances in the ancient Greek mysteries of Eleusis. Very much relates to the Open Center's long-term work on the Western mystery tradition, where we've done a long series of conferences on the Western mysteries. And the second one too, where we, with Tony Bossis, when he spoke about the use of psilocybin with people facing the end of life and their anxieties around that. So this has been very much in sync with the Open Center's long-term themes. We're delighted to be doing this. We couldn't be doing it without Tony Bossis. We met Tony a number of years ago through our work with The Art of Dying. And Tony has not only been crucial in bringing together this series, but he is also our moderator. So I'm going to pass it over to Tony in a minute so that he can tell you more about the series and some of our speakers this evening. But let me just say a few words about Tony himself. He is, Tony Bossis is a clinical psychologist. He's clinical assistant professor of psychiatry at NYU Grossman School of Medicine, where he's been conducting research on a mystical and psychedelic experience for over a decade. He was director of the Palliative Care Research Program and co-principal investigator of their landmark study in 2016 on the significant reduction in emotional distress of patients with late-stage cancer. He's also a training supervisor of psychotherapy at NYU Bellevue, and as those of you who've been watching movies recently will know, he's been featured in some new films about the whole psychedelic resurgence that we're going through right now. So, Tony, I'm going to pass it over to you, but it's been such a pleasure to work with you. You have really been at the heart of all of this, and I'm so glad that we have done it. This has been a truly enjoyable series, and I hope it is just the start of many further programs the Open Center can do on this profound and resurgent area. So, Tony, over to you.
Thank you, Ralph. And thank you, Ross and Ralph, for the Open Center initiating this and sponsoring this. It's been really enjoyable, and I cherish our long relationship together over the years on various topics. It's been a great series. Today's week 4, and it's really going to be another exciting night. Really honored to bring these colleagues and friends in tonight. We're in for a treat once again. First up is Rick Doblin. I know Rick now a long time. I was just telling him a few minutes ago that, back in the mid 80s when there wasn't anything happening in research, the little MAPS newsletter, one page, was the beacon in the darkness. There's somebody out there. There's someone out there doing this. And for over 35 years or so, he's been a foundation of this incredible movement that now is unrecognizable in terms of where it was 10 years ago, even 5 years ago. So really exciting time. Rick has been a pioneer in sponsoring MDMA research and running MDMA trials. just decades of experience that he'll tell you about tonight. And one of my favorite Rick Doblin trials is an update, not a trial, but an update on the famous Good Friday experiment back at Morris Chapel that I spoke about a few weeks ago. And so just a delight and a real pioneer and a real mensch, which is the important thing. And then we have these two, speaking of pioneers, really two people who've kind of created a whole new clinical domain in this work, is working with PTSD patients with MDMA, some of this incredible groundbreaking work, with their often seemingly refractory trauma histories and from a host of life events. And to see Michael and Annie, who've been just incredibly groundbreaking in their work of training and guiding sessions, having patients and people with these horrific trauma histories be transformed and begin to integrate that into a life that is now really livable. And they're very stunning and poignant stories. And I think we will all be really taken back tonight by the stories, by the history, by the healing that takes place in those session rooms with Annie and Michael, and with Rick, overseeing all this data. So I'm very excited, and I'm happy and proud to hand this over to Rick. Rick, great to see you here, and it's all yours, my friend.
Thank you, Tony. Yeah, it did start with a one-page newsletter. We've come a long way. I was the only employee for 7 years. Now we've got about 105 people, or even more potentially. Every time I turn around, there's more. So I'm going to a bit of the history. Unlike Brian, I'm not going to go back thousands of years, but I'm just going to go back about 100 years. So I will share my screen. It'll just take a second to set this up. Okay, what's happening? Huh. Oh, there we go. Okay. Okay. Does that look right to everybody?
Yes.
Okay, great. All right. Get through this for now. Okay. So I'm just really proud to be here with Michael and Annie and Tony and everybody else. So I'll start with history. We'll get more research data and therapeutic approach from Michael and Annie, and then I'll do a bit on the future. But really the history for me begins with Stan and his statement that psychedelics are to the study of the mind, what the microscope is to biology and the telescope is to astronomy. And we know that people were burned at the stake for things that they saw through the telescope. Eventually, we have come to see that the telescope is sort of a neutral tool. And similarly, people have spent their lives in jail for what they've done with psychedelics. But I think we will now reform how we think of psychedelics as well. This slide is from almost 2 years ago. This is a slide that was presented at the American Society for Clinical Psychopharmacology. It's a psychedelic looking slide. The reason I show it here is that it was created by the FDA. And when they give this presentation, they also announced that what they're going to be doing is creating a guidance document for sponsors who want to do research with psychedelics. So there's thousands of these guidance documents on all different things, but this is going to be up and coming for psychedelics. So the main message here is that the FDA is really open to what we're doing. After decades of suppressing the research, and then starting in 1992 when they said they'd open the door to psychedelics again, and now we're at this incredible moment of the flourishing of psychedelics. This chart is just really to further emphasize the psychedelic renaissance. This is a chart of psychedelic publications. And if you look at where we were at in the late 60s, early 70s, it took almost 30 years to get back to that point of the same amount of new publications. But now we're just enormously beyond that. And I think our society has learned an awful lot over the last 50 years, and I think we will be successful in reintegrating psychedelics into our society. Our structure is this. MAPS is a nonprofit, which I started in April of 1986. And in December of 2014, we started the MAPS Public Benefit Corporation, which is a for-profit company. And it is 100% owned by the nonprofit. So people donate to MAPS, get tax deductions. MAPS invests the money in the for-profit and does the research. And then eventually, if we get approval for selling MDMA, whatever profits we make from the sale of MDMA will go back to the mission of the nonprofit for more research. So there's no private ownership. MAPS is 100% owner of the the Public Benefit Corporation. But we created that. We had a decision to make. Should we just sell MDMA at our cost, or should we sell it at a profit? And we felt that there's so much research that needs to be done, and we might eventually exhaust our donors if we kept asking for donations. So we're not going to maximize profit, we're maximizing public benefit. And that's the main difference of a public benefit corporation. That's been made possible by Ronald Reagan signing this law in 1984 that provides incentives for developing drugs that are off patent. And these incentives are called data exclusivity. And what that means is that if we make MDMA into a medicine, we have exclusive use of our data for what will end up being about 6 years. In Europe, it could be up to 11 years. The difference then from data exclusivity and patents is if somebody else wanted to develop MDMA for PTSD, they could do so. They would just need to generate their own data. So we're not blocking anybody from doing anything. And so data exclusivity is exclusive use of your own data. Now, this is just to show that what I'm going to be talking to you about is just from large numbers of other people. This is just some of the MAP staff and all the different functions. This is the Public Benefit Corporation, and I'm sure this isn't even up to date. And since our founding in '86, we've raised over $100 million in donations. And once we added that, I was like, oh my God, that's a lot of money. However, it doesn't really seem like it's a lot of money, because in the last 2 years, we've raised probably about $35 million. But the for-profit companies have raised about $1 billion. So the key advantage of the for-profits is the access to capital. And so that is our challenge, actually, going forward. How do we raise the capital that we need to expand to meet the patient need? And can we keep doing that from philanthropy? So that's the question that we're trying to answer. But we have the freedom to do whatever we want right now because we don't have anybody asking for their money back. We don't have anybody that we have to pay back. We have been given over $100 million in order to benefit the public and do this work. So this is as far back as I'll go in history, 1912. MDMA was invented by Merck. They were trying to evade a competitor's patent to get at a particular drug, and MDMA was one of the drugs that was in the synthetic route, and they just patented everything. And they didn't do anything with MDMA for about 15 years, and they did some animal studies. They found it not to be of interest. The animals didn't say, oh, I love my fellow animals. They didn't do anything. And then again in 59, they did more studies in animals, and again, decided that it was not of any interest. In the 1970, the Controlled Substances Act came in and criminalized all sorts of drugs, including a drug called MDA, which was methylene dioxyamphetamine. Sasha Shulgin was an incredible chemist whose first psychedelic experience was with mescaline, and it was a very spiritual experience for him. One of the main things he said about it is that he realized that he wasn't having a mescaline experience. He was a human having a human experience mediated by mescaline, meaning that it was something that came from inside him. It wasn't this artificial thing that the drug did for him. And he then manufactured and synthesized hundreds and hundreds of different psychedelics and sort of is the godfather of MDMA, sort of rediscovered MDMA. Took it with him, experimented with himself, then took it with his wife Anne, and then found it of incredible value. And then they shared it with a small group of 12 people, and they got different impressions of what this drug was, and they all thought it had great potential. And so then they give it to the secret chief. And the secret chief was Leo Zeff. He was the leader of the underground psychedelic therapy movement. He had been close to retiring. And once he tried MDMA, he realized that he had a new mission, that he wasn't going to retire, and he was going to introduce psychiatrists and therapists to MDMA. And over a period of time, from the middle 70s to the early 80s, around 500,000 doses of MDMA were used in these quiet therapeutic settings under the code name Adam. But it escaped from those settings and it became used recreationally as ecstasy. And that's what attracted the attention of the government. Most of this MDMA was actually made by MIT students at night in the lab when nobody was watching. And it wasn't illegal. But it became such a popular party drug that it was used at the Stark Club in Dallas. There's a documentary been made about the Stark Club. And that's really what attracted politicians in Texas. And it was clear when I learned about MDMA in '82 that it was both a therapy drug and a party drug. And this was Nancy Reagan, Ronald Reagan, just say no, escalation of the drug war. And so it was doomed. It was obvious that it was doomed. I started a nonprofit before MAPS to protect it and to argue against it. And once the DEA moved against MDMA, which they knew only as ecstasy, they didn't know about the therapeutic use. That's me in the picture there, right before I walk in the DEA headquarters to ask for a hearing to determine whether it could stay as a therapeutic drug legally. We were winning in the court and winning in the court of public opinion. We had Brother David Steindl-Rast talk about MDMA being a tool for meditation. We had Rabbi Zalman Schachter comparing MDMA to the Sabbath, not your party people, but really changing the perceptions. We had therapists talking about it. And so it was very much a different narrative. So we were winning there, winning in the courts also. And the DEA freaked out. And they, Gene Hayslip here, emergency scheduled MDMA in the middle of 1985. Interestingly enough, the first effort to criminalize MDMA was a crime, meaning that they did not have the legal authority to do what they did. The Attorney General had the authority, but had never subdelegated it down to the DEA to do emergency scheduling. So the first year or so that people got busted, everybody had to be let go. But even though we won in the court of the administrative law judge, who said that it should stay in Schedule 3, meaning criminalized for recreational use, but legal for therapeutic use, the DEA rejected the recommendation and kept MDMA illegal. We sued a couple times in the appeals court, won both times. Eventually, DEA lawyers figured it out, how to meet the standards of the appeals court. And I realized the only way through is science, through medicine, through the FDA. Our first 5 protocols from Harvard, from UCSF, University of New Mexico, Albuquerque, all rejected until the FDA in 1992 approved a study with Charlie Grob and I, and this was actually going to be, we were asking for MDMA for cancer patients with anxiety. FDA said they would open the door to psychedelic research, but they would treat it as if they treated any other drug, which meant that we needed to start with phase 1 dose response safety study. So we did that. Then near the end of the 90s, Charlie said, oh, this MDMA is way too controversial. There's all this stuff about neurotoxicity. And we were having a little bit of problems. We could have addressed it, but the FDA was a bit slow to approve the MDMA cancer anxiety study. The reason we were focusing on that was because of neurotoxicity concerns. We were working with people that would have a year less to live. People didn't show problems from neurotoxicity, but some of the researchers were saying it's a time bomb, it'll happen later. And that never happened. But Charlie decided to switch to psilocybin. So that began the work that Tony ended up doing and others at NYU and Hopkins. In 1999, we started with MDMA for PTSD, which was really, I think, the best choice. And we did this study in Spain. It was heartbreaking that the Spanish anti-drug authority shut the study down for political reasons before it was completed. But fortunately, Michael showed up at a conference, the world's first conference on ayahuasca, and we spoke about trying to do work together. Michael wanted initially to do an offshore clinic, and I said, I think we can go through the FDA, let's do that. And Michael agreed, and he was an expert in PTSD, and so that's how we started in the US with FDA for PTSD. While this is happening, of course, the rave scene is growing and all of this, and this is Madonna at a concert. Have you seen Molly? After a while, ecstasy, which had been very pure at the beginning, got adulterated by underground dealers. And so the new name Molly for molecule, which was supposed to mean pure MDMA. But this was very popular during the 2000s. This is Miley Cyrus talking about Molly. So we have this rise of popular culture use, but also the growth of our science. And so by 2016, now this is 30 years after the start of MAPS, we had enough phase 2 data from studies in Israel, Switzerland, United States, and Canada. And from that, we went to the FDA and said, could we go to phase 3? And FDA said yes. And so now I will turn it over to Michael and Annie.
Thank you, Rick. Yeah, really fun to be doing this. We're newcomers. We only joined Rick in the effort 21 years ago. He'd already been at it for quite a while by then, but his vision and all his efforts are what made it all possible, along with all those other people you saw. So it's just a great privilege, and it's fun to be part of this symposium too, because it's one of the things I've loved the most about this work is the small community of researchers that we all get to, share ideas and know each other. So Charlie Grove was the first person Rick introduced me to about 10 minutes after we first spoke. And, the work that you're doing, Tony, at NYU, and all the work at Hopkins and elsewhere, it's just a great experience of all these committed people working on this together. So thanks for having us.
Yeah, and it's fun to do something with you, Rick. We don't get to do that very often. It's fun to be back at the Open Center. I came to I think it was the Art of Dying in the early 90s. So it's really fun to do this with Michael. Yeah. Good to be here tonight.
Yeah, Rick and I and Annie and I have been communicating pretty much every day for 21 plus years, but lately we don't get to do much together. So that's fun too. So we'll share some slides, hopefully. Yeah. Can you see that okay? Yep. Yeah. Okay, so as Rick said, we first spoke in 2000 and then got our first protocol approved in 2001. So those phase 2 trials, as Rick said, were finished in 2016, leading to breakthrough therapy designation and moving into phase 3 since then. For those of you who aren't familiar with the phases, these are FDA terms, drug development phases. And phase 1 is laboratory and animals. Preclinical comes before phase 1. Phase 1, which is what the first one Charlie Grove did, is with healthy volunteers. And then phase 2 are relatively small studies testing safety and efficacy in small numbers. And then phase 3 is similar to that, but larger. And that's where we are now. And that's what allows you to then file a new drug application with FDA if you have successful phase 3 trials. So these are the 6 phase 2 studies that led to this designation. And papers were published on about 4 of them. You can see those. So these were 6 studies at 5 different sites in 4 different countries, all showing good effect sizes and good safety profiles. So, we're going to talk about these results quickly, but I'm going to go fast because you can read all the details in the various papers. These are some of the papers. The top three are three of the papers from the two of the studies we did in Charleston. First was with crime-related PTSD, mostly childhood sexual abuse and rape. We had the longest follow-up we've had for that, 42 months on average. And then we did a similar study showing that the same approach worked well with veterans and first responders, as well as with crime-related PTSD. And then the studies in Switzerland and Boulder had mixed cause of PTSD, as did the ones in Israel and Vancouver that haven't been published yet. So this is the design, just so you have an idea what we're talking about. So going from left to right, first, careful informed consent, medical and psychological screening by outside psychologists and physicians. And then these first vertical green lines are the preparatory sessions. So we have 3 90-minute sessions to prepare people for the experience. And then those brown triangles are the only 3 times that MDMA is administered. And those are a month apart, 8-hour sessions with two co-therapists, in most cases followed by an overnight stay in the clinic. And then the green lines following the experimental sessions, the all-day sessions, are the integration sessions, 90 minutes each. And the first one happens the next morning. So we pay a lot of attention to preparing people and a lot of attention to helping them integrate the experience afterwards. So people are randomized to either placebo or low-dose comparator on one hand, or to full-dose MDMA. And whatever they get the first time, they also get the second time. But then a month or two after the second one, and after the integration sessions, then we repeat the assessments, measure the symptom levels, and then we break the blind. And if they got randomized to full dose, then they move on to a third full dose session. If they got randomized to something other than full dose, placebo or comparator, at that point, then they can go back to the beginning and go through it again. So they all could have 3 full dose sessions eventually. Phase 3 that we're going to talk about is similar, but it doesn't have the crossover until later. It's just 3 sessions of MDMA-assisted therapy versus 3 sessions of all the same therapy, but with inactive placebo. And then we have long-term follow-ups a year or more later. We published the results of the pooled results of those 6 studies, and we had a large effect size even when you subtracted the effect of the therapy alone, which was actually also clinically significant. People that had failed prior treatments had pretty substantial effects from all that concentrated therapy, but it was much greater with the MDMA. So the effect size of the whole package was even larger, up to 1.9 after 3 sessions. So this is a graph of that. The top line is all the therapy without the full dose MDMA, or without an active dose, which turned out to be 75 to 125. The bottom line is the drop in the PTSD scores with MDMA active doses. And we also looked at, so the vast majority of people had a clinically significant response. We also looked at the people that no longer met criteria for diagnosis of PTSD. And with the therapy alone, it was 23%. And these people had all failed prior therapy. So pretty good results. But at the conclusion of the study at 2 months, 56% of the people with active treatment no longer met diagnosis. Again, this was beyond the 88% who had a clinically significant response. And then a really interesting feature that we see consistently is that at the end of 1 year, the number of people who no longer met criteria for PTSD was even larger. So unlike, say, just drug treatment, which tends to fade after you stop the drug, this is very consistent with the way we understand it, that MDMA is a catalyst, kind of like Rick said, Sasha Shulgin said, that it wasn't a drug experience, it was a human experience. So this is consistent with this being MDMA being a catalyst to help people start this process and catalyze the process that then keeps unfolding. We found a number of other things that you can read about in the papers and upcoming papers, but we also interestingly found improvements in depression scores, sleep scores, post-traumatic growth scores. We found no change in neuropsych testing, and we had a good safety profile in these well-screened people under controlled conditions. Here's a graph. Again, you can read about the details, but this is the neuropsych testing that we did in 2 of the studies. And it showed the blue is before 2 doses of MDMA and the orange is after, and 2 months after. So we can see no sign of memory problems or other neuropsych effects. This is MDMA. Rick's talked a little bit about it. It's often called a psychedelic, which I think fits if psychedelic means mind manifesting. But it's quite different from classic psychedelics like LSD or psilocybin. So I think it was Dave Nichols who suggested the term entactogen, meaning to touch within, referring to this quality of putting people more in touch with their own inner experience as well as more connected with others. And often a sense of well-being and insightfulness and less perceived lack of control than classic psychedelics, but that's relative. Especially in people with PTSD, sometimes it was quite challenging and scary even. So it's important to recognize that. It's a complex pharmacological profile that I'm not going to talk much about, but there's a lot of monoamine release, serotonin especially, effect on serotonin receptors, and also increased levels of a number of hormones, including oxytocin and prolactin, which have interesting psychological effects. Like everything else, every other drug, MDMA has side effects. It reliably increases blood pressure and pulse, which is why we screen people for cardiovascular disease. And, in so-called recreational settings, there have been a few deaths, usually heat stroke or dehydration, or sometimes conversely, people have died of brain edema, a few people from too much hydration, and MDMA decreases the ability to clear water a little bit. So not to be taken lightly, but there have been no deaths or unexpected drug-related serious adverse events in research settings, MAPS and other research. So it has a good safety profile for pure MDMA in a controlled setting with carefully screened people. These are the most common side effects from our first phase 3 trial. Self-limited effects that weren't a big problem. You can see those. And so after the end of those 6 studies, we learned quite a bit. We found that the active dose range is 75 to 125 with an optional supplemental half dose. We found that lower doses, 25 to 40 that we tested, caused more anxiety but weren't helpful. So that turned out to not be a very good comparator dose because it actually interfered with the therapy. So we arrived at the inactive placebo, and we found that the same approach worked with PTSD from a range of causes, including war or sexual abuse. So a little bit about our phase 3 research. Our agreement when the FDA said we could go on to phase 3, we actually went through an extra step of special protocol assessment to have an extra level of agreement about the details of the protocol. And we agreed on, based on our large effect sizes, even being conservative, that we only needed 2 studies of 100. We knew we needed 2 successful studies. We only needed 100 people each, according to our statistical calculations. So they're called MAP1 and MAP2. The MAP1, which is now completed, you'll notice the last 10 people are a different color dot because because of COVID, we realized we needed to stop there, and FDA agreed that made the most sense. So we went ahead with 90 people in MAP1, and now we've started MAP2 as a confirmatory trial. as I said, the design is 3 sessions of either active dose of MDMA or inactive placebo with the same kind of preparation and integration that we had in phase 2. And these are where our sites are that just finished the first phase 3 and are now doing the second one. We've got 11 in US, 2 in Canada, and 1 in Israel. So we're not sharing the details of the results yet until we get our peer-reviewed publication, but we can tell you that we had a small p-value and a large effect size. We replicated our data from phase 2 and had a good safety profile. So we're also working in Europe. We met with the European Medicines Agency a few years ago, and now we have sites in these countries where we're starting an open label lead-in for a subsequent phase 3 trial. So now we want to talk a little bit more about the therapeutic approach, and Annie can join in a lot more since I've been doing too much talking. This is our treatment manual that describes the approach. You can download it free at MAP's website if you're interested in more details. And really, we owe a great depth to many teachers who went before. Stan Groff has been one of our primary teachers.
As many others at holotropic breathwork training.
Yeah.
Yeah.
Yeah. And many others, including a number of people who had studied with Leo Zeff, and Ralph Metzner was a teacher. So we've basically taken what we've learned about working with these states from these pioneers, and we've kind of combined it with our own experience working with PTSD. So
this is our room, and you can see that we're on opposite sides of a futon where I have the blood pressure machine and the thermometer for temperatures on one side. Michael would work with the video equipment. I'd have the music on my side. It's a non-directive or inner-directive, self-directed approach. We rely on the inner healer. Reclining, that's optional, but most people do end up reclining, and headphones and music and eye shades if they're comfortable with that. Often people with PTSD have trouble with headphones and eye shades, but usually they get used to that. So it's an alternating inner focus. Try to get people to be inside for the first hour at least, and then come out and talk to us if they have things they want to talk about throughout the day. And usually the trauma comes up. We usually don't have to bring that up.
So there's no schedule for that. We encourage people to see what comes for them. Usually it's about half talking and half focusing inward, but it can vary a great deal in either direction. And we think it's important not to have an agenda about that.
In our setting, Michael, there's a bathroom right behind Michael, so people don't have to go outside of the room. We always have flowers, and it's a very aesthetically pleasing, quiet room. And we trust the inner healing intelligence, which is something we learned from Stan and other people at Breathwork, which is seeing what the inner healer wants to come up with, and trusting the inner healer of each participant. And sometimes that takes a little bit for people to get used to. It's not what they usually do in therapy. They're usually more goals. And yeah, you want to say more about that?
Yeah, so that we learned that idea from Stan. Stan says if you enter a non-ordinary state with a medicine like this or some other way, it's as if you're doing it with the intention for exploration and healing, and it's in a good setting, it's as if there's an inner radar that scans for what experience is most useful for you at that point. And that's what he calls the inner healing intelligence. And we've just seen it borne out again and again and again. You know, I know it sounds a little woo to some people, scientists especially, and I get that. But, you know, as I've thought about it over the years, I practiced emergency medicine for 10 years before I went into psychiatry in 1991. And it's, it reminds me of something I didn't think about much at the time, but if people came into the emergency room with a gash in their arm, for instance, I didn't know anything about how to heal that. I only knew how to remove obstacles and create favorable conditions for healing. And so that's what we're doing. And another analogy I like is to immunotherapy for cancer. We don't think that's woo-woo because we understand the immune system relatively well, but it's the same kind of approach. How can we use tools to help the person use their own healing capacity? And we've mentioned the importance of preparation and integration. This can really stir things up, and people can have second thoughts or backlash, or they can have a lot of emotion coming in the days following that could be very challenging if they didn't have good preparation and good support. So it sounds a lot different from most therapies, of course, 8-hour sessions, 2 therapists using MDMA, but we've been struck by the fact that by how often elements that are recognized as being parts of other kinds of therapy arise spontaneously. And I wrote something about this in the MAPS bulletin. If you'd like to, you can get that online too. But in a way, we think it's validation for the inner-directed approach in many ways, because what we see is all these things come up to different degrees and in different orders for each person. So, safe supportive setting is important for any kind of therapy, and that's important here. People virtually always end up doing imaginal exposure, which is a term from prolonged exposure therapy. At some point, they start revisiting and talking about the trauma. It's just we don't tell them when to do that. We don't ask them to do that. We just encourage them to be open to whatever comes. And at some point, that'll come. Sometimes it comes right away, but sometimes people have other experiences first that seem to prepare them better for that. So we think there's value in not directing it too much. We don't set out to do cognitive behavioral therapy, but people always recognize cognitive distortions at some point and correct them. The transference can be very powerful, and that's a great opportunity.
Rich to work with.
It can be very rich.
Mm-hmm.
Psychodynamic stuff always comes up. People may come in, a veteran comes in with war trauma, but at some point, usually quite a lot of the time, they end up talking about relationships and childhood and psychodynamic things. We give a lot of attention to the body. We pay a lot of attention to the body. So there's overlap with somatic therapies. We've been struck, and we've done some measurements actually about how often people become more aware of their normal multiplicity of their psyche, talking about their different parts and kind of working with them. So it's a little bit like internal family systems or voice dialogue or psychosynthesis, other therapies that recognize that. People can have powerful transpersonal and spiritual experiences. There can be a very powerful corrective attachment experience. For so many people with PTSD have attachment injuries from early life.
The MDMA enhances the trust for that to happen.
Yeah. And people can have amazing archetypal imagery that reminds me of Jungian therapy sometimes. So another thing it reminds me of is this quote I've always liked from Irvin Yalom: "A therapist must strive to create a new therapy for each patient." And we take it maybe a little further to say, or maybe the therapist must strive to allow and encourage each patient to create a new therapy for themselves. That's what we aim for. So it's a little bit like curling. We made this slide when we did a training in the Netherlands a few years ago. So you set something in motion, but then you don't push it around afterwards. You only give it a little help occasionally. And of course, to do that, to be present in an 8-hour session can be challenging for therapists. So we just want to mention the importance of all of us doing our own inner work and exercising self-care so we can be there in these intense states with people.
And self-care really is talking about doing your own work, having your own therapy, having your own method of inner exploration is so valuable to do this work with people. So here's a few quotes. I don't know why they call this ecstasy. And we've had a number of people say this. It's not always easy with PTSD, having PTSD, but it's possible for the work to happen. Maybe one of the things the drug does is let your mind relax and get out of the way, because the mind is so protective about the injury. So, I think this says it for itself, just how so much is cognitive for people, and they're back in the trauma. They're not in the present. I have respect for my emotions now. What's most comforting now is that I can handle difficult feelings without being overwhelmed. And so this speaks to how important the integration is. It's not just what happens in the MDMA sessions. It can be quite a bit of work, having feelings again for people that maybe have been numb or shut down. It feels almost like the inner healer or the MDMA is like a maid doing spring cleaning. It's as if you thought you were cleaning before, but when you got to the things you didn't really want to deal with, you'd stick them in the attic. If you're going to clean the house, you can't skip the stuff in the attic.
I think most psychotherapists would be pretty stoked if a patient came in and said this kind of thing.
And I think that's the first time in my life that I actually stopped thoughts and relaxed. And when I did that, that's when I started feeling that oneness with everything, merged with the whole room and everything, and just was. I learned better how to just be. So here again, the present moment, not thinking about the future, not thinking about the past, being one with everyone, everything.
And this was a veteran we'll talk a little bit more about in a minute. And this was after several sessions of challenging processing of the trauma. Mm-hmm. And then he had this experience. And it's, one thing we looked at, as some of you know, in the studies at Johns Hopkins, and I think you've used it in New York too, Tony. They've used the mystical experiences scale, and they found, at least in a number of the Hopkins studies, that the benefit people got from the session correlated strongly with whether or not they'd had a full-blown mystical experience. So we started using that method too after talking to them about it. And interestingly, what we found with MDMA was it wasn't as common to have a full-blown mystical experience as it was with psilocybin. We did see it about a third of the time, but what was different was whether or not people had that did not correlate with outcome on PTSD symptoms. We think for the people that had the mystical experiences, there was a very important part of their healing. And for other people had much different experiences and had a similar level of benefit. So it, again, fits with kind of the variability and the value of not being too directive in this kind of situation.
Here's the process continues on unfolding over time. As interesting as the sessions are, I know from experience now that it's even more interesting what happens after the sessions when you're making connections. So speaking to the growth that can happen, the self-growth that can happen, and what can happen for people.
Yeah, I think one of the challenges in the preparation and in the integration really is helping people understand that it's not just about what happens in the MDMA sessions, because understandably people kind of get attached to that I've got to get everything done. I only have a limited number of sessions, but what they discover, what we suggest to them strongly ahead of time and remind them of later, is this, and they tend to realize, yeah, it's really striking how much this process continues to unfold over time. And that, of course, makes for a really rich possibility for integration. Mm-hmm. So why does MDMA help in this way? We don't know for sure. And we mainly have been studying whether or not it's helpful and whether or not it's safe, but many people have been studying about why it might be helpful. So we want to talk a little bit about that briefly. But I also want to preface by saying I'm really making a plug for not falling into reductionist thinking, because what we're seeing in these sessions is so broad and deep and rich and varied that I think it has a lot to teach us about the nature of healing, not just about how do you cure PTSD with MDMA, which is a good thing to know too. So I don't want to lose sight of the forest for the trees. But having said that, just to touch on a few exciting areas of exploration about the possible mechanisms. There's data from Emory, from Barbara Rothbaum and her team, showing that MDMA promotes fear extinction in rodents and now in healthy volunteers. So that's an interesting fact. There's a lot of talk about memory, maybe partly memory reconsolidation, that people, the trauma comes up in a setting where it's no longer associated with danger, it's associated with safety and support. And so maybe when it gets stored, it has different associations. There's really interesting work about increasing neuroplasticity, a number of these compounds. And this work about showing that oxytocin-dependent social reward learning circuit that gets closed normally in adolescence, I think, for rodents, and that it may get reopened again. So that really fits with some of what we see too. So, and this was just a cool study to mention. Gil Dolan asked Rick for some MDMA to study octopi, and it turns out octopi are not social creatures. They stay isolated in their little cave, except during mating season, or if they've gotten MDMA, then they come out and mingle. So we're not so different from octopi, I guess. So I am going to mention a couple details about some of the neuroscience that fits particularly well with what we see clinically. So it's a lot more complex than this, but this is part of it. We know that people with PTSD have increased activity in amygdala, fear center, and decreased activity in prefrontal cortex, higher processing center, and decreased activity in hippocampus, even smaller hippocampal size. So that would fit with a lot of anxiety and not really able to process and connect with what you remember since the trauma. That's one way to see it. We know that MDMA, this is in healthy volunteers. There's now data coming in people with PTSD, but we know that MDMA has some effects that are opposite of those effects of PTSD, decreased activity in amygdala and increased activity in prefrontal cortex, as well as hippocampus. So what this fits with from a clinical point of view, in our opinion, is this idea of the window of tolerance, or the optimal arousal zone. And this is, I adopted this from one of Pat Ogden's books, but other researchers doing trauma research, including prolonged exposure, have reported this phenomenon that if the vertical axis is the arousal level, if people are hyper aroused, overwhelmed by anxiety, when they try to process their trauma in therapy, it's not effective. It can even be re-traumatizing, and they have high dropout rates for that reason. Conversely, if people are emotionally numb and disconnected, they might be able to talk about the trauma, but it doesn't seem to be effective. And people with PTSD have both of these extremes very often. So the idea is there's this optimal level of arousal where people can tolerate revisiting the trauma and where it can be therapeutic. So one thing we think MDMA seems to do is give people a number of hours in that optimal arousal zone, so they're able to process the trauma in a way that they hadn't been able to without the MDMA. And the other interesting, even more complex area of research is about the effect on the neural networks, in particular, especially the default mode network, and the way the networks relate to each other. A lot of this work comes from Robin Carhart Harris at University Imperial College London. So, and what he's finding, among many other things, is there's a decrease in rexatate functional connectivity between hippocampus and prefrontal cortex, and an increase between hippocampus and amygdala. And for us non-neuroscientists, Mendel Kaelin, I'm getting ahead of myself.
This is Robin.
This is a paper of Robin Carhart Harris. This is not specifically about MDMA, but drugs that affect 5-HT2A. And Robin's idea is about this idea of relaxed beliefs under psychedelics. The idea that if you have PTSD, or I would say if you're a human being, but maybe especially if you have PTSD, we tend to walk around with these overvalued prior beliefs from our cortex. And that can make us discount or information and experience from the limbic system from an outside doesn't get through so clearly because of the influence of these prior beliefs. So, that, like with PTSD, they might be things like, it was my fault, or I deserve to be treated that way, or the world is a dangerous place, or I'm a murderer for going to war, those kinds of strong beliefs. And so Mendel Kaelin, a researcher in Robin's lab, used this analogy to explain this to us non-neuroscientists. He said, it's as if you've been going down a hill in this track and you can't turn out of it. You always have to take the same track with maybe some wobble on the way down. So this effect on the brain is like new fallen snow. And that fits so well with what we see. Suddenly people who have been caught in this rut, these old patterns of suffering,
see it differently.
Have the possibility to see it differently, to respond differently. Yeah. And that we see it all the time. And another part of this, we talked about the elevation in oxytocin as well as other hormones, and a number of people have done quite a lot of work with that. It's not fully understood, but this effect, the prosocial effect, really seemed to help with trust and the therapeutic alliance. And people with PTSD so often have had their trust violated. It's a real obstacle to successful therapy and forming an alliance, and MDMA really seems to help with that. And as Bessel van der Kolk says, traumatized human beings recover in the context of relationships. So it helps to not be too afraid to have those relationships. So, as I said before, I'm advocating for not being reductionistic. So I want to give you an example of what I'm talking about. So this
is from Nick, who was in the acid test. This is his process.
Yeah, the book Acid Test, if you've seen that. And the reason we can say it's Nick is because he's given permission, and a lot of his process is described in the book. But it's a good illustration. I wish we had time to watch all the 6 MDMA sessions and all the integration sessions, but since we don't, I'll give you an overview to kind of illustrate what I'm talking about the richness of this process and the value of not having an agenda to limit it too much.
Or how it unfolds.
Yeah. So Nick was a Marine who did 2 tours in Iraq as a turret gunner. And he had a lot of symptoms and had a lot of combat. But one of the things that bothered him the most, he told us, was this rage that would erupt. And he'd yell at his wife and then feel terrible remorse. So he told us that in the prep session. So that sets the scene for the first thing that happened to him in his first MDMA session, which I'll tell you about. So the first thing that happened was...
So first tell him about the boxes.
Oh, yeah. Okay. So if the box has a yellow line around it, it was an MDMA session. If it doesn't, it was a integration session. And if it has a thick yellow line, it was 125 milligrams. And this width of yellow line is 75. So Nick was randomized to 75, and he had 3 of those, after which his PTSD was gone, but he qualified to cross over and had some very valuable and powerful experiences with 125. So he had described this monster, the rage. He described the rage as this monster that was erupting from his chest. And he said, my image is, I'm trying to strangle it, and it's trying to stab me in the side. That was his struggle with the rage. So one of the first things that happened in the MDMA session, after he got used to some anxiety from elevated heart rate, is he had this amazing experience of reconciling with that, what he thought was a monster, but he realized was actually the warrior. And he said who
saved him in Iraq.
Yeah, who allowed him to function in Iraq. And he said, I realized I was so afraid when I saw what he was capable of. And when he said he said, I know it's part of me, but he was able to recognize this phenomena of different parts. And he said, I realized I was so afraid of what he was capable of from Iraq, I had him locked in a cage. So no wonder he was enraged. So he had this direct experience of going to the cage and opening it and embracing this part of himself and having a real healing there. And that was what came first, which then allowed him to go on and process a time when his Humvee was blown up and his friend was killed. And it seemed that it was necessary for him to reconcile with the warrior before he could really do that. And he said, I've never been able to feel it or to remember or see it or feel it so clearly before.
So that was the second session.
That was in the same session, wasn't it?
Oh yeah, that was in the same. Yeah,
that
sorry.
was later in that session.
That's right.
So that was really amazing. And then the next day he said, I feel really interior. He needed a lot of time for himself, which we had prepared him for, the possibility that was likely and that was really a good thing. The problem was in the past, if he'd been not communicative and, wanting time for himself, it was because he was really struggling and maybe about to explode in a rage. So that caused a lot of challenge in the relationship with his wife. And we worked with both of them a bit, and then they worked together, and they were able to process that really well over the next week or two with some support. And they came through that, and he was feeling really good. And he was an artist, so he drew this about his first session when he looked the trauma in the eye. That was a depiction of his first session. So on to the next session, in which he then was able to process some challenges from childhood. He didn't have an abusive childhood, but he was quite poor and was bullied. He was able to process that, and there was a lot of powerful work with the transference. He said, I feel like I'm spilling the beans to my parents. And then he later went on to a great deal of remorse about moral injury, about the fact that he had killed people and calling himself a murderer. And he felt really blah and stuck, and came to a realization that there was some part of him that had wanted to go to Iraq and die. Mm-hmm. And when he came to that conclusion after several hours of working with being stuck, then he was able to finally really let the tears come.
Have a lot of grief.
A lot of sobbing. And so that seemed really helpful. But the next day he said he felt as if he'd had his defenses ripped away. So this is an example of the importance of integration, because, we prepared him for that possibility, and that's how he felt. And he was struggling quite a bit. But, when we were talking about in the integration session is when he said that thing about the stuff in the attic, because he was really having a hard time. And I said to him, it's interesting. We talked a lot about what you need for integration before that, but I said, MDMA doesn't always give you what you want, but in our experience, it always gives you what you need.
Well, you said the inner healer, not MDMA.
Right, the inner healer.
The inner healer.
Thank you, Annie. I did say that, yeah.
Yeah.
And that's when he said, yeah, I guess I can get that, because I thought maybe everything was going to be easy after that first session because I had healed so much. And now I realize, you can't skip the stuff in the attic. So we worked with that. It was quite challenging. He came in later and we did some body work and an integration session with all the rage, which was really helpful. And then he felt much better. He was reporting better self-care. And then his next session, his third 75 milligram session, he was really able to grieve the people that he had killed and come to a sense of forgiveness from them and from himself. And then his first 125 milligram session, he had this kind of shamanic-like experience, vivid imagery of dismemberment, followed by this beautiful scene around a campfire with three parts of himself: the sage, the little Nicholas, and the warrior, all sitting in council. Quite beautiful. And then he had an image, and I think it was the next session. He says, I'm having this image, I'm sitting at a desk, and the MDMA materializes and brings me what I have to work on next. And it just brought me my service record. And it said, you need to review this with Michael and Annie so it can be filed in its proper place. So, which is what we did. And that's, after doing that, that's when he had that experience of being one with everything, which led him to asking for music that was like the call to prayer. And he had this beautiful experience of appreciation for the people of faith.
The other culture. The people he'd been fighting were also people of faith. Mm-hmm. And he finally said, the warrior is on his knees. He finally let himself feel time to dust off the camis, hit the showers, and hit the rack after a lot of hard fighting. And then after that, for quite a while, his wife had been encouraging him to do this exercise of writing things he loved about himself, but he hadn't been willing to do it. But now he was willing to do it, and he read that to us. And he, went from all that calling himself a murderer to now having this experience. And this last session, frankly, was pretty much a celebration of all the healing. And he ended by saying, I'm happy to be alive and grateful for the experience. So that was Nick's journey. And just to go quickly, if you want to think about those in therapist language, what happened was first he had gained respect for his defenses or his protectors. Then he did some powerful imaginal exposure. He needed integration time, at which time he did couples work, then did self-expression through art. Then he worked on transference and childhood issues, moral injury, self-judgment, death wish, finally had catharsis. Then he was concerned about losing his defenses or protectors. We did somatic processing with his rage, which led to better self-care and enjoyment. He started eating vegetables.
Yeah, he wouldn't even eat lettuce or tomato on his hamburger before. And then he decided one night after his session to try some vegetables and ended up loving them. So then he did some more processing of moral injury, a lot of kind of shamanistic archetypal imagery, a sense of integration with his parts. And then kind of memory reconsolidation. He reviewed
the file,
the file from before the war, through the war, had a mystical experience, had compassion for his enemy, former enemy, and people of faith. And he had a lot of satisfaction, more self-love, joy and appreciation, and happy to be alive. So I think you can see, we're not into knocking other forms of therapy, but if you can compare this route to this kind of route, some people would rather focus directly on just the index trauma and the PTSD symptoms. And there's evidence that for a fair number of people, you can decrease PTSD symptoms by this approach. And it's more rapid in a way. But you can see if you want that highway, you can get there more directly, but many people, you're going to miss a lot of this countryside. So many people would probably prefer something more like this, and some people wouldn't. So just quickly mention other areas that are so important that we don't have time to talk about. MAPS is, with the leadership of Shannon Carlin and Sarah Sheld, has developed a code of ethics. This is a really important effort in all this kind of work, as you know. We're facing the challenge of scaling up in anticipation that we will get approval, and we're going to need a lot more people that have some training in doing this kind of work. And increasing cultural and ethnic diversity is a big challenge that we're putting a lot of attention to and really important. We're revamping the training program to figure out how to train enough therapists. And there's a lot of effort by many people on how to get this paid for people. So after approval, and progress on all those fronts. So take it away, Rick.
Thank you. Well, I'll be very, very brief to leave time for questions. And just wanted to say, Michael, and they just showed you the brand name for MDMA. I won't go back to my slides. I'll just say that we do have a brand name. And because we've talked a lot about the inner healer, the inner healing intelligence, our therapy we sometimes call inner directed therapy, the brand name that we've come up with is InPath, the inner path. So InPath is the brand name. We're about 2 years away, potentially less, potentially a little bit more from what we think is likely to be FDA approval. The big variable is related to COVID and how quickly we can enroll people in our second phase 3 study. But we think it's imminent. We think it's very likely. And we think that the long-term changes are going to be initially psychedelic clinics. We already see a bunch of them now with ketamine. And we think there will eventually be thousands and thousands of these psychedelic clinics. And they're not going to be like MDMA clinics or psilocybin clinics or ketamine clinics. What we find is that the therapists want to be cross-trained in all the different modalities, and they want to be able to develop sort of personalized medicine unique to each patient. As Michael and I were saying, that the patient would sort of really help guide these choices, and that there'll be psychedelic centers where you can go to and you could then have a range of psychedelic medicines that are available to you. We are very hardworking on this idea of insurance coverage. I think that's likely to happen. I think when you take a longer term look, that this will be cost effective. We've already worked with a healthcare economist. It looks like it pays itself back in 3.5 years for the insurance companies. So I think that the future for us will be MDMA for PTSD, then group therapy. We need to start exploring group therapy, which we're going to probably do at the Portland VA initially, then at the Bronx VA and elsewhere. And there's a whole range of other indications for MDMA than PTSD. We're going to try to explore a lot of those. Ben Sessa and David Nutt in England have just done a really interesting study on MDMA for alcohol use disorder. And not surprisingly, a lot of people who are driven towards running away from their problems with drugs or alcohol have a lot of trauma. And if you clear up the trauma, then they won't need to escape so much if you can help them handle that. And we have a whole series of studies that we're doing with the various researchers who are affiliated with the VA who've developed a lot of these non-drug therapies for PTSD. So while we have our inner-directed therapy, and we think it's really optimized for helping people heal, and as Michael and Annie talked to you about, you can use a lot of other elements of therapy, of other therapies in this approach. It's just more when the patient is there and when it comes up, when it seems logical, rather than imposing it from on top. But we are funding studies that would look at combining MDMA with prolonged exposure, with cognitive behavioral therapy, cognitive behavioral conjoint therapy, where one person has PTSD, it affects the relationship, and both of those people would get MDMA in the therapeutic context, and that was with Candace Monson and Ann Wagner. It worked out great. So there's a whole series of other modalities, in a sense, that could be developed for MDMA, and we're trying to really implement this through the VA, the Department of Defense, and elsewhere. And so I think that the future looks really, really bright for psychedelic medicine. The need is great, and we're working through the FDA systems and EMA to try to get these drugs approved. So with that, I'll turn it back to you, Tony, and others for questions.
Thank you, Rick, Ann and Michael. Incredible history, incredible work. Ross, do you want to go to Q&A now? I think we will. Neera, are you there?
Hi, Tony. Hi, everyone. This is Neha from the Open Center, and I will be moderating our Q&A. So I know we had a bunch of questions on our chat box, or in our chat box, rather. The best way to kind of shift gears, I think, would be for folks to send in their questions, and we can just, I believe we can just kind of start from where we, I don't know what would be the best approach here, because I think we had a bunch of questions earlier and I don't want to miss those. So if you had a question earlier and it was during the presentation, if you can start sending those in now, I'll just kind of read off and then we can hand it off to whoever is.
Neha, this is Ross. I'll jump in real quick. I did see a lot of questions on the slide deck. This is such a fantastic slide deck. Is this available for public consumption?
Yes.
Beautiful. Okay.
Well, ours is it Rick for you too?
Oh yeah, for sure.
Okay. So what we'll do is we'll get that from the both of you, and then we'll share that with everybody registered. So don't worry about going and tracking it down. We'll send it to you all so you can have it.
Great.
Ross,
I know Jade, I know people were asking questions too about some good resources, and Jade, a good friend from MAPS, is here in the audience today, and I know she was posting some. So if people want to find some good other resources, scroll back up. I don't know how far back it was that Jade was posting about that, but I know she posted a few things. So I'll throw that out there, and then Neha, if you want to take it away with any questions you see that you think would be good.
Sounds good. Yeah, there's quite a few great ones. So I'll just start. So we have the latest question from Randy. Are there still neurotoxicity concerns with MDMA? So maybe we can just kind of keep it somewhere. I want to get to as many questions as possible. So maybe somewhere between a minute to a minute and a half for the questions.
I'll do it in like 10 seconds. No.
All right.
The FDA doesn't care about neurotoxicity. We've done neurocognitive tests before and after two different cohorts of our studies, no changes. There's no functional consequences we can see. We've just done dog and animal studies again and found no evidence of problems. The FDA wanted us to redo some of the stuff. So I think the neurotoxicity concerns are related to dose and frequency. We don't see that in the dose and frequency that we use. So I think it was mostly a red herring designed by NIDA to justify the drug war. Not to say that, super high doses or, a lot of frequency could cause problems, but it doesn't kill brain cells. It's nerve terminal degeneration. It can happen, but we're past that. The FDA doesn't. In phase 3, we're not even looking at neurotoxicity. They haven't asked us to look at that.
Great. Thank you. So I'm actually going to go a little bit further up. There were a couple questions directly related to the research study. Michael and Annie, this might be for you. What if the client, this is in regards to the therapy, what if the client has the impulse to move, stretch, or take off the eye blinds? Do you encourage or discourage movement and open eyes? Seems like eye contact would deepen the connection.
Sure, yeah. They can do all of that. They can take the eye shades off. There's time where we're looking at each other. And of course, now with COVID, they're masks, but and getting up and moving around. Some of the times when we were doing blood pressure, in our studies, sometimes we'd have to do blood pressure every 5 minutes for a while or every 10 minutes. So that would constrain the movement a little bit. But yeah, as the session went on, and now in phase 3, the blood pressure is only done 3 times. So yes.
And and along with that, we do in general encourage people to do as much as they can on the mat, in order not to be distracted by the outside world and having to attend to things other than their inner process. So it's a balance. Sometimes, movement can be really important. We encourage people to move their body, let their body move, but we encourage them to do as much as they can of that on the mat. Keep it vertical. Well, they're horizontal anyway. So it's a balance between those things.
Great. And I know there was a go ahead.
I'm going to jump in with a quick to the team. There's a lot of questions in my life, people asking me about MDMA and future studies on autism or Asperger's spectrum type diagnoses, given its incredible ability to increase socialization and even access to affect in a new way. Are there any studies on your horizon for autism or Asperger's?
Well, we did the one study with MDMA for autistic adults with social anxiety, and the results were great. That was a phase 2 study. We don't have the resources right now to move other indications into phase 3, but that would be one of the ones. But the FDA has basically said to us that they don't want studies in subpopulations. So when we looked at autistic adults with social anxiety, the next study that we would do be social anxiety from any cause, rather than just probably focusing just on autistic adults. And we found that a bunch of the people who thought they had autism, we had to screen out. They were just so socially anxious that it seemed like it. So I think if we were well-funded like these for-profits, we would have the resources to start doing other indications. But right now we think that'll follow after we get PTSD approved.
Great. Just a follow up, there was another question by Mark. In your published studies, your research has used racemic MDMA. Does your data support that the racemic mixture is more effective against PTSD than the S plus isomer?
So I answered that in the chat, but I'll just say that
Gotcha.
that we've tried. I've tried, and many of us have tried the different isomers of MDMA, and neither of them were as good as MDMA racemic. And I guess maybe one thing that prompted that question is that ketamine in generic form was something that Johnson & Johnson, when they looked at making ketamine for depression, they used one of the isomers, S-ketamine, but the only reason they did that is because they could patent it. And it's not, I've also done the isomers of ketamine. And similarly, I think that the racemic is better for therapy, for personal exploration. And so we never looked at the isomers in research. It just never seemed, first off, we weren't looking for patents. And secondly, I don't think either one of them would do anywhere near as good as MDMA.
Great, thanks for elaborating, Rick. We have a question from Alexandra. Do you think that therapists in private practice and not just clinics will be able to provide MDMA-assisted therapy? And maybe to add on to that, how soon?
Well, I'll say something that Michael and I can talk, Sarah, but just that we have this formal dispute with FDA right now. And one of the issues that the FDA is saying is that they want a doctor on site. And we don't think that that's necessary. We don't have to have a doctor on site in phase 3, but I think they're looking forward to post-approval. They also wanted MD or PhD to be the lead facilitator, which also makes no sense and also isn't something that we have to do in phase 3. So we will for sure work with private practitioners. They will have to set up their clinics. Whether they'll need to be a doctor on site is a big poison pill, I think, from the FDA. We need a doctor to do the initial screening. We need to have a doctor on call, but I don't think we need a doctor on site. That'd be the main thing that would be a problem for small, private practitioners setting up their own clinic.
Most of our phase 3 sites are at private practice offices.
Great. On that note, could you elaborate a little bit more on how you're recruiting candidates for the next phase 3 study?
Well, go ahead, Rick.
Not well enough. Well, costs us $10,000 a day in our overhead, basically. And so we need to recruit a lot faster. So I think one of the things that we're talking about, COVID has slowed things down a lot, but I don't know if Michael and I, if I've even mentioned this to you, but we talked about sending a message to Bessel van der Kolk, to Dick Schwartz, and the best place to recruit from is PTSD therapists who have patients that they know have moderate to severe PTSD who are stuck, and having them refer to us. So we're going to try to reach out to teachers of trauma therapists, and Candace Monson, who's president of the International Society of Traumatic Stress Studies. I think that'll be more effective. But right now there's a lot of people applying, but a lot of people who are traumatized don't actually have severe PTSD. They just have problems with trauma, so they get screened out.
Great. From Bruce, we have a question. Any thoughts to combine MDMA with EMDR?
Well, we got that question a lot, and I used to do a lot of EMDR when I used to have time for it. And my opinion is I don't think you need EMDR when you have during the MDMA session. You've already got eye movements. I'm not clear what the significance of that is, but I think it could be really useful for integration, because that integration is a time when whatever tools the therapist has for helping people explore and integrate their experience further can be really useful. And I think EMDR could be really great for that. If people have a lot of emotions coming up or they feel second guessing what happened, that kind of thing, the integration period can be challenging. And I think it's
in the couples study that we did, the 6 couples that we did with Candace Monson and Ann Wagner, we used CBCT, cognitive behavioral conjoint therapy, for all of the integration sessions, except for the morning after the MDMA. But it was incredibly powerful for the couples to work with CBT in integration.
Great, thank you. Another question from Deanna. Have you seen any psychosis? Does MDMA induce psychosis with someone suffering from bipolar, for example?
Well, we have not seen psychosis. We've not enrolled anybody with bipolar type 1. We have enrolled some people with bipolar type 2. We don't think that's because MDMA couldn't be helpful or safe in that setting. We just, in the research protocol, we had to taper people off all their psychiatric medicines. And we thought if somebody with bipolar 1, it might not be safe to taper them off their mood stabilizer. But there's no reason to think that couldn't, you couldn't work with that clinically. I'm sure, and there's more to be studied. There should be a study of that. I think and we haven't enrolled anybody with a history of psychosis. It's interesting that there's a researcher in New York now who's discussing doing a study with people with schizophrenia with MDMA assisted therapy. So I think it should be explored. I don't think there's an inherent reason why it couldn't be safe or useful that we know of.
This next, oh, sorry.
Oh,
Were you going to elaborate?
Well, I was going to say the container might need to look different from how our studies were, the protocol and how our studies were.
And I think that's true of a number of things. Like we didn't include people with dissociative identity disorder, at least we didn't intend to. And that doesn't mean that I think it could be a very, very powerful treatment for people with DID. It just might need a better container, more support, perhaps a residential treatment or more flexibility. So I think a lot of these things post-approval will be really important to study.
Mm-hmm.
Wonderful. Thank you. I'm going to combine, there's a lot of great questions coming in, so I'm going to combine these next two. You mentioned PTSD from any cause. Does that include people with adverse childhood experiences as defined by ACEs, verbal, physical, sexual abuse, neglect, etc.? And then also to build upon that, just in terms of the population that you've worked with, is there any work being done with diverse populations such as refugees, other people who have suffered additional trauma, aside from war veterans?
Mm. Yeah, well, the first part,
The ACE.
The ACE, it's interesting. We definitely have enrolled a lot of people with complex PTSD and adverse childhood experiences. We have not predominantly enrolled people with single incident trauma by any means. And interestingly, we have some preliminary data about this before the first phase 3 study, we did an open label lead-in because we had 80 new therapists. They were experienced therapists, but 80 people who had not done this before that we had trained. After phase 2, we had a small number of therapists who had worked on phase 2 relative to how many we needed. So we trained more than 80 we trained a few hundred, but we ended up selecting a little more than 80 therapists to work on phase 3. And so for them to have a chance to practice and get supervision, we had a protocol where each new team treated one person with 3 MDMA sessions and all the integration and preparation, open label and then it was all videoed, and then we gave intense supervision about that. So they had a chance to practice legally that way. And as part of that, we tracked how many adverse childhood experiences people had had. And what we found, this is preliminary and it was open label, but we found both for males and female, there was no correlation between outcome and whether or not they'd had adverse childhood experiences or how many they'd had. So the people with a lot of adverse childhood experiences responded just as well as the people without them. So that is different from most therapies for trauma. Remains to be seen how that's going to hold up, but that was encouraging data about that preliminarily.
And for refugees, the teams in the Netherlands are going to work with refugees. Is there some other place?
Germany might as well.
Germany.
Yeah. Yeah, we're trying to, work with more of those more diverse populations in general, and refugees are certainly a group that really need help.
Thank you. What are your thoughts on the value or necessity of facilitators or clinicians having their own personal experience with psychedelics prior to working with them in a therapeutic setting?
You want to take that, Rick?
Yeah. I would not go to a meditation teacher that never meditated or to a yoga teacher that didn't do yoga. I don't think it's essential, and we're never going to require it, but I think it's tremendously helpful. We have a protocol with the FDA where we've given about 90 therapists so far who volunteered for it, their own MDMA experience, and then FDA has put a hold on a protocol to expand that to more. So we did a survey of the people that were in the study that received MDMA and asked them how important did they think it was for their own personal growth, but for their own professional growth as well. And it was almost unanimous that it was extremely helpful for people. And when you think about it, there's of the 8 hours of the session, more or less, no different order, 4 hours or so, people's eyes are closed, inner experience, the other time they're talking to the therapist. And so if you've done it yourself, you can have a sense of what's going on when people are quiet. I mean, you don't know the content, but you can see if they're in it, if they're resisting, or if they're open to it. And I think it gives you a big insight to do that. And you can also ask certain kind of questions or be leading them in certain ways. So I think the experience is tremendously helpful for therapists. We don't want to require it because we don't think you should ever require anybody to do a drug. So the way we think about it is that it's not that every therapist who's done MDMA is better than every therapist who's not done MDMA, but that every therapist who's done MDMA is better than they would have been if they wouldn't have done.
Great. So we have a question from Michael Bridges. I read that 70% of MDMA patients spontaneously started to communicate with parts of themselves, like the vet with his monster. Is this true? Is this similar to internal family systems therapy?
Yeah, great question. Yes, it is true. I trained in internal family systems therapy, and Annie's had some training in it through her Comey training. So we very quickly became interested in how often people were talking about parts. We never set out to do internal family systems therapy because we were trying not to lay another therapy on what we were doing. But if people started talking about parts, then that was a very helpful background to have in helping them work with it. So we decided to track this, and we made a little scale about whether or not parts came up in the session, and if so, what happened with it based on internal family systems principles. I have talked to Dick Schwartz about this a lot, who's developed internal family systems. And so I checked the scale out with him. He said he thought it made sense. It's not a validated scale, so this is preliminary. But what we did was, in that study, people got either 30, 75, or 125. And we soon found that 75 and 125 were both very effective. So, but after each session, we record whether parts had come up, if so, what happened with it, who brought it up. And what we found was that with the active doses, parts came up 78% of the time, versus a little less than 30% of the time with inactive placebo, or with low dose. So there was something about the active doses of MDMA that really increased people's awareness of their parts. And for those of you that are familiar with internal family systems, it also brings forth a lot of self-energy to go with that. That's an IFS term. So I saw in the chat briefly, I wasn't able to really follow the chat, but somebody mentioned the video that Dick Schwartz plays. And that's a video, if some of you have seen that, that's a video of Nick. And the way that came about was maybe 5 years ago, Dick invited me to give a keynote at the annual IFS meeting in Providence. And I showed that a 10-minute clip of Nick. And it was like 500, mostly trauma therapists, all IFS therapists. And like there wasn't a dry eye in the house. There was a standing ovation, not for me, but for Nick. And then Dick said, "Can I use that video?" And I asked Nick, and Nick said, "Sure." So it's, there's a very strong connection between the parts work and what happens in MDMA sessions quite often. So thanks for bringing that up. And I think understanding it in terms of more self-energy is a really good way to understand the MDMA effects.
Thank you. this I think is kind of a good segue to the next question. Curious about, this is from Rebecca Ross, curious about the therapist's experience of witnessing this transformational process. What has moved you in this process? What do you give value to regarding your own ethics as a practitioner? How has this felt different than traditional forms of working with trauma? I'm sure it's a very comprehensive experience, but anything you can share about that?
Well, just to see how people change, just for one thing, how they look from the time they come in to the time they're finished with the study. It's just remarkable how different people look. In the first study, we our participants went 3 days after their session. They went to an independent rater to do the caps, and he'd met them for the first caps, but they went for a repeat. And he said he could tell every single one that had MDMA when they walked through the door. So, and then just to see how their lives are transformed, having babies, getting married, things that they never thought would happen to them. Soldiers, veterans who had PTSD for 10 years and are finally sleeping after one session and getting better. Numerous.
Many people have told us it saved their lives. People said things like, well, I was definitely going to kill myself when my second cat died, and that cat's 13. Things like that. So it's incredibly, the 8-hour sessions are tiring sometimes, but I usually feel invigorated and nourished as well as very tired.
And the first study, the people had it was an average of 19 years of therapy and PTSD, right?
Yeah.
For childhood sexual abuse, rape, and to see them having tried everything, talk therapy for that long, and then get better.
And sometimes it's really hard. Sometimes people don't get better, and sometimes people have really intense suffering that they have to go back to their life after a little glimpse of something different. That's usually not the way it is, but there's that side of it too.
And then there's the side of the psychosocial issues for people that have had PTSD for that long and can't get a job, and all their relationships are kind of falling apart. And, to see what they're going back to and what our whole structure is for helping people with PTSD, and seeing how, the failure of our systems for those people. We can help them with the MDMA session, but we can't help what happens after they go home.
I'm actually going to mix it up a little bit so I can get to some of the questions we've asked later on. Looks like we have a question about dosage. Does it look like the protocol will remain at 3 sessions with 125 milligrams of MDMA with a 62.5 booster later?
Sort of. We've changed the doses a little bit just for economy because so we're using 120. We have 2 size capsules now, 60 and 40, because it's much cheaper not to have many different capsule sizes. So we've adjusted it slightly that way. The other thing is we found that 75 in one study was actually a little more effective than 125 in the one we did with veterans. So we arrived at a design for phase 3 where we start with 80. And this is always, whenever I say a dose, that's the initial dose, and the supplemental is half of that, 1.5 to 2 hours later. So we start with 80 the first session, and then we have an option, and the default would be to go to 120 for the next 2, but the decision can be made not to if the person doesn't want to, or there's, the team decides with the participant that actually they maybe rather go back to 80 after the 120, or there's a little flexibility there.
Great. What is the timeline for MDMA sessions followed by integrative sessions? How close in time do the different sessions happen?
Well, 3 to 5 weeks apart for the MDMA sessions is what we've done. And then the first integration happens the next morning after each session. And then the others, are spread out over the next several weeks, depending on, what works best for an individual.
And usually the second integration session is that next first week when people might be having more emotions and more process that they want to see you and do some therapy with. In the couples study that we did 2 weeks apart, 2 MDMA sessions, 2 weeks apart, and then we moved it to 3 weeks apart, plus all the CBCT that went with it.
Thank you.
And then the last integration session, it's good. The third of those 3, it's good to have it pretty close to the next experimental session. So you've checked in with somebody not too long before the next MDMA session.
But in clinical use, it might be better to have longer integration, between the sessions, because so much happens.
Yeah, for the expanded access program, what we said, people can have 1 to 3 sessions in a 6-month period. So there's a little more a step toward the direction of clinical use where it can be individualized according to what the person needs.
Great. There was a question I saw earlier that I in particular am very biased towards as a yoga instructor. You mentioned there was body work done. Can you elaborate a little bit more on that body work and how responsive the client was and so forth?
Yeah. So that body work was how Michael and I were trained in holotropic breath work. There's emotional release work that was developed by Stan and his wife, Christina, where you work with different parts of the body. It's not like massage. They still have their clothes on. Places that have tension and you're applying resistance to that place. For Nick's session, we worked on a mat with a mat on the floor and just worked with his rage in similar ways, containing the rage and letting him really explode. In our phase 3 studies and how we've trained people, we've asked the therapists only to use body work that they've been trained in. And so we don't encourage people using body work. And really in the MDMA sessions themselves, it doesn't come up that much that people might want to hold your hand or might want to hug, might want you to sit with them on the couch, but it doesn't really come up as much. But in the integration sessions, using techniques like Gestalt or somatic experiencing, things that you're trained in would be Hakomi, would be all things that you could use.
And what we think is really important is to bring attention to the body and encourage work with the body. But very often the person can do that themselves. If you encourage somebody to breathe into it and let their body do whatever it needs to do, that's sufficient most of the time and better a lot of the time. So what we've said in the training is, as Annie said, we don't want anybody to just start doing body work because they've seen us do some on a video unless they've been trained. But we do think it's essential that they be willing to give some nurturing touch. So like if a therapist didn't feel comfortable holding someone's hand or putting a hand on their shoulder or giving them a hug if they wanted to, then we think that would be a real problem. But if they don't know how to do direct body work and can just encourage people to let the body do it themselves, that's sufficient.
And then we encourage people to get massage or do yoga after the session, so that that can be part of their spiritual path, to have something that they can do for integration.
Can I ask a question for the team, for Rick and the Mythoffers? This is a meta question. The last few weeks we've been exploring how these medicines can, the implications for what is consciousness, what is all this, what is self. and how are the tools to understand all that. And you've been speaking tonight about this incredible process of going within and this inner healer guiding the person through suffering to transformation. After all the experiences you've seen over the years, where does it leave you in terms of your thoughts about nature of self and those more complex, broader topics? Big one.
That's a good one. Yeah. Well, I don't think about that much. I'm much more practical.
You're much more what?
Practical. I think about fundraising, regulatory affairs, the nature of self. It's like the FDA doesn't care. But I would say that I think the big thing is that I go back to the Copernican revolution, right? That we used to think that the Earth was the center of the universe. And that's the big thing that the telescope got people in trouble for, to realize that's not the case. So I think the big thing is we tend to think of our ego or ourself as the center of the universe. And the shift that you make is that we're not the center, that we're a tiny part of rotating around something much, much bigger. But I would also say that there is this ability, I think, to tap into things that have happened in the past that we didn't directly experience through this collective unconscious kind of idea, that I think that's part of our bigger self, and that you can experience that under psychedelics and under other ways. And that I think there's a mistake that a lot of people make, that they think that those lives were their lives. There's somehow or other this continuity of ego. I don't believe in reincarnation in that sense, that it's the soul that goes from life to life, but I think you can tap into things that have happened in the past. There's some resonance that you can get to. But again, I think in a therapeutic setting, the main thing is if people start experiencing these things, you help support them in doing it, whether it logically makes sense to you or not.
Now, one thing that strikes me is kind of along those lines is, when we always talk to people about the idea of the inner healing intelligence, which, as Annie said, that people don't often are very puzzled by that. No one ever talked about their problem that way or addressing it that way. But I'm struck by, it makes sense to people. They know this on some level, even though cognitively they don't know it. Cognitively, they may argue with it. But you can see that there's a way that we're talking about some common thing that we all know. And that is similar to what Rick's talking about, the collective unconscious. And
once they have the experience.
How much well, even before, once they have the experience, then they get it. But even before that, I've been struck by, they don't understand it. They, on one level, may not even believe it. But the fact that they're even entertaining it to the degree that they do says to me that there's a level in which they know that. So, and to me, what it, as I said, it's showing us a lot about the nature of healing and growth for humans, I think. If you look at, I think psychiatric medicines can be very important sometimes, but I think the idea, the way psychiatry is caught in this idea of, we know these diseases and we have these drugs that treat them, that falls so far short of what you saw happen to Nick that, to me, that's one of the most fascinating part, is not only what does it mean about the nature of consciousness, but what does it mean about the nature of healing and what people really, really need.
And how often the present moment experience comes up for people and they get grounded in knowing that for the first time with MDMA, and understanding that people meditate for years to get that feeling is so amazing. We saw a lot of transpersonal experiences with people where they saw spirits in our room. They had past life experiences, synchronicities. I mean, so many things that I just didn't think would happen with MDMA, frankly. But thanks for the question, Tony.
Thank you. And, you said something, Michael, that we see a lot in the psilocybin too, as you know. people have taken it for the first time, maybe in their 60s, maybe 70s, apprehensive, understandably, and as they should be. And it begins to happen, and you hear the same thing you just, I think, implied. Oh, I know this. Okay, I know, there's some sense of this is familiar. This is part of my inner experience, even though it's the first time with that kind of dramatic encounter.
Yeah, that inner
Over
knowledge.
and over again.
Yeah, I don't think we've ever had anyone that said that was just a drug experience.
Yeah.
They all recognize it as their own.
Right. And we never see that in the psilocybin. No one says that was a 5-hour drug experience. That wasn't access to something larger within me or with outside of me, but that was the nature of reality in part. Incredible.
Yeah.
Yeah.
Great. So we have about 4 more minutes. So I'm going to get to maybe 1 or 2 more questions. We have a question from Anna Tamayo. I think this is pretty interesting. Are all the interventions in these studies individual? What do you think about group therapy with MDMA? And I know for a fact that group therapy is becoming more and more popularized in the psychology space, so psychotherapy space. So anything about that and maybe the future of MDMA and group therapy?
Yeah, we're very enthusiastic about that. We're working on a study design now in Portland to do a group therapy study. I think it's a great idea, not only because it makes it more cost effective, but also the group experience can be so powerful and helpful for integration.
Community.
Yeah, although my guess is that the individual therapy will be more effective than the group therapy. I think there's something about telling to the therapist what's going on that kind of reinforces the thing. And I think there'll be less of that in a group process. I think also we've talked about how it would be good to have a group that has the same kind of trauma. If you had a mixture of veterans and women who've been sexually abused in the same group, it might not work as well. But it'll work better. I mean, but even for the group therapy study that we're doing, the design is everybody gets an individual session first.
Yeah.
Or they have a group session together. Because when you're super vulnerable from PTSD, I think it would be hard to have your first session in a group.
Yeah. And then you
I agree with
then you
that.
could have tell your story or have the transference with the therapist. And yeah.
Yeah, we'll find out.
Yeah. And the Portland study will be at the VA. So it will have people with well, even then, there's veterans that have what they call MST, military sexual trauma. So I don't know if we put in the protocol that it should be the same kind of.
Yeah, I think so.
Great. Last question from Al. I wonder how you evaluate whether a therapist is prepared or capable for the possible complex responses. That's actually very interesting. If this is successful and hopefully can be available on a wider scope, how would there be some training behind this, and what might that look like?
Well, I'll say one thing about how we know people are not ready, and then Michael and Annie can say how they think people are. There was one of the therapists that said, when she was offered the opportunity to try MDMA herself, she said, I don't think I want to do it because I might lose control. And I was like, well, how are you going to help people lose control? And experience difficult stuff. And she later self-selected herself out of being a therapist. So that's one way to tell.
Well, this question is one we're spending a lot of our time wondering about now. We're not sure how you tell. We're in the process of kind of redesigning the therapy training program. We have data showing it's been working well, but it's not very scalable for the largest, the kind of numbers we think we need. So that's one of our biggest challenges. How do we train more people, and how do we know if they're getting it when we don't have this intense level of contact and supervision that we've had with all the therapists so far? So any ideas, please send them our way.
Supervision is going to be definitely part of it.
We're consulting with, education experts, pedagogy people to try to help us figure that out. So I hope we will.
we may find out more after the fact. So we'll have patient bill of rights and things where patients can report back if they thought it was, appropriate therapy or helpful. So it'll be tricky, I think, to tell.
Thank you. Well, that's all the time we have for this evening. This has been such an informative and quite enlightening talk and presentation. So thank you, Rick, Michael, Annie, Tony. Thank you all for being here today. Thank you all for your wonderful questions. Definitely keep the conversation going. I know there were a couple chats, support groups mentioned in the chat box, so please look out for those as well. I believe the recording will be shared, and the slides as well, Ross. I think we might be able to share the deck.
And Nia, I just wanted to jump in and thank everybody again, and say we will share the slides. Also, I just mentioned in the chat, Jade from MAPS is on here. Follow her on Clubhouse if any of y'all are on Clubhouse. Jade is in so many good rooms on this topic. Rick's in Clubhouse too. You can follow him. I'm occasionally in there. You can follow me, but not probably as much. Jade is super active on this. And I just want to say too, we typically have breakout sessions for this. When the Q&A is this good, we cannot break away. So I just want to thank Michael and Annie and Rick and Tony. This has been, this is like back-to-back weeks where the Q&A is just so engaging. I don't want us to break away.
Ross, can we get a copy of this Q&A too?
Yeah, totally. We have the report. Yeah.
Great.
And so I'm like, in a way, I'm sending an apology to all of y'all on here that we didn't get the little breakouts, but in a way, I'm like, oh my God, it's been so good. So I'm seeing some heads nods and thumbs up, and we just really think like the questions, it makes me so happy to be a part of the Open Center community because the questions are so high quality. And it's amazing to read the chat and to see people answering each other's questions. Yeah. And then I'm thinking like, these people know what's up. This is not just like bullshit answers to questions, So thank you. Thank you to y'all, Open Center community, Annie and Michael and Tony and Rick and Ralph. Nia, you killed it tonight.
Timothy.
I was texting with Nia and I said, you're doing such a good job on the Q&A. And she's like, I was not prepared for this at all. Such a good job.
It was amazing. People put their finger on the main questions we're asking ourselves all the time.
So thank you everybody for showing up. Thank you for bringing the great questions. Thank you for participating like you have, bringing the energy that you have. And I can't believe we have 2 more weeks. 2 more weeks. So much love to everybody.
I enjoyed it.
Bye.
Bye.
Thank you.
Bye, everyone.
Thank you.
Michael and Annie, I have to go off to the adherence raters now.
Oh, wow.
Their meeting. It's going to be really
cool. My goodness.
It's good.
Oh, gosh. Did you get dinner?
No, I didn't.
Rick.
I'll get it.
A window into Rick's life for those of you that are still on.
I'm 4 minutes late, so I think I got to go down. That's great.
Take care.
Bye. Thanks, Timothy. Thanks, Neha.
All right. Good night.
That was really fun.
Awesome. Take care. I'm ending the meeting now.
Bye-bye.